is Pedro Bassi. I'm a postdoc at Touchstone of University, and here I will talk about Touchstone, which was our organ segmentation benchmark presented at NeurGroups. The Touchstone benchmark has several qualities that make it different from other benchmarks. First, it's an organ segmentation benchmark about the segmentation of 9 abdominal organs in CT scans, and it has a really large training data set with more than 5,000 CT scans from 76 different hospitals. So this gives AI models an advantage by seeing a large population, diverse population. They can generalize better to new hospitals. And now this brings us to our ideals for a medical AI benchmark, the ideals that guided this Touchstone benchmark. The first one is external evaluation. So for a long time, AI was trained and tested in the same data set. But it's known that AI can perform really well in test sets that are similar to the training data and then fail dramatically when it goes to a different type of data set, like an unseen hospital. So here we test all AI models in a hospital never seen during training, the Johns Hopkins Hospital. And also our test set is much larger than the test set of previous benchmarks. We have more than 6,000 CT scans for testing. And the large test set size is very important to give us statistical power. So we can really look at the final ranking and be sure that one model is better than the other, not by chance, but because it's really better. Additionally, we not only present an average ranking, but we do some analysis by groups. So we have the metadata of our test sets. We separate patients by age, sex, race, diagnosis, and more factors. And then we analyze how well the AI works on each one of these groups. And if there is some bias where the AI performs better in one group than the other. And finally, we have the inventors' participation. So in this benchmark, we invited the creators of the state-of-the-art organ segmentation models like NMNets, like Monai, to train their models in our data set. Then they sent us their trained networks, and we, as a third party, performed the evaluation in the OOD test sets. Here are our results. So the best performing models overall were MedNext, convolutional neural network from the KFZ, and Medformer, a hybrid between a convolutional neural network and a transformer. And another really interesting finding is that overall, the models that are based on the NNNet framework performed really well in this benchmark, often achieving the best position. So this shows that the NNNet is a really strong base to build segmentation models. Additionally, here we have the ranking per organ. And this shows some interesting things. So some models are not the best overall, but they are really strong for a single organ. So for example, the UC Transnet is really strong for the aorta, but it's not the strongest overall. So some models are really good at certain structures, but not overall. So this is interesting to have the per organ rankings, so you can see these hidden strengths. Here are some analysis of confounders. So it's really interesting to see, for example, that the age has a strong effect on the AI performance. So when patients go over 50 years old, you see here the performance steadily drops with advanced age. And this probably the reason is that the organ boundaries for older patients are more difficult to identify and to segment, making this performance drop with age. Also, performance drops with cancer diagnosis. This is expected because the cancer can deform the organ, making it more difficult to segment. But interestingly, performance also drops for female patients. Maybe one reason is that male patients have bigger organs in general, overall, which are easier to segment. But another problematic finding is that the performance is overall higher for white patients than for African American patients. And this shows a problem in the training data set. So the public data sets do not have many of these patients, making the AI performance lower for these patients. Here show the importance of test set size. So these plots show the ranking stability. We take our test sets and we take different random subsets of these test sets, and then we test on the subsets. So if the ranking is very stable, so the ranking is the same for different test sets, you see the plots like you see in JHH, which looks like a line. This means that no matter which subset you take, the ranking is the same. So you can be really confident in this ranking. However, when you have smaller test sets, like the total segmented or official test sets, when you have different subsets, the ranking can change dramatically. So this means when you have a small test set, you need to be careful, because probably the ranking is not really trustable. Now I will talk a little bit about our next work. So this is our Abdomen Atlas 3.0 dataset, which we'll use for the next benchmark. And this dataset, unlike the other one, this one focuses on tumors. And this dataset is the only one with CT scan, masks, and reports for each one of the training samples and testing samples. So this dataset is also very large. We have more than 9,000 CT scans, each one of them with radiology reports and organ and tumor segmentation masks. We have tumors in the liver, kidney, and pancreas. And here we have both the structure reports, which are really organized and divided by organs. And we also have the narrative reports, which follow more like a free text style, mimicking the reports at the UCSF hospital. And another very important thing is that this dataset has a really large number of tumor annotations, both as masks and as reports. So to construct this dataset, we gathered many public datasets, and then we noticed that many of these datasets did not have annotations for multiple tumors. So some of them only have annotations for one tumor type, like liver, but no annotation for the kidney, for example. So our radiologists look through all these images with the help of AI, and then they segment the tumors, all the liver, kidney, and pancreas tumors in all these data sets. Overall, this triples the amount of our tumor segmentation masks we have in these public data sets. And then, with the help of AI, we translated these ground truth tumor segmentation masks into ground truth reports. And we made sure that these reports fully match the information in the mask. So we have ground truth masks and ground truth reports for all samples. All this data is public, and some uniqueness of this data set is not only is it the only data set with reports and masks for all cases, it's also the only data set with pancreas subsegments. It also includes the segmentation of blood vessels around the pancreas and staging for PTAC. So, yes, that's it.
Thank you. Any questions from the audience? Just curiosity, so I noticed that you did compare it to a segment, or did it rank on the first slide you had with the initial, did you actually rank it comparatively with the other models, or is that a...
For total segmentator, you mean the...
Yeah, when you go to your, I think it was your second, the next slide, yes, this one here, was it on this Touchstone report?
Total segmentator is not here. We have the nets.
Okay.
Not total segmentator, because all the models here are trained in our data sets. So as total segmentator trains in different data sets, we do it a little bit.
Oh, I understand. I got it. Okay. So it was retrained. Understood.
Yes.
Thank you very much.